All right, welcome to The Explainer. Today, we're jumping right into a really high-stakes clinical decision. What's the absolute best and safest way to treat a patient with symptomatic carotid stenosis? We're going to break down the evidence piece by piece, so you're ready for any tough questions that come your way.
Okay, I want you to picture this. You're in your FRCS Viva. The pressure is on. An examiner looks you right in the eye and asks you to defend your management of a patient who just had a TIA. You need an answer that's sharp, that's evidence-based, and that shows confidence. This explainer, it's designed to give you exactly that answer. So how are we going to build that perfect response? We'll do it together, step by step. We'll kick off with the why this was even studied, then move to the how by looking at the trials. We'll dissect the critical results, acknowledge the nuances and limitations, see how it changed everything, and then finally, we'll wrap it all up into a perfect consultant-level summary. Right? Let's get into it.
Okay, first things first. You've got to frame the problem. Why is this even a question? And why on earth is there such a rush? Getting this right sets the stage for your entire answer. So, here's the absolute crux of the matter. After a patient has a TIA or a minor stroke because of a carotid plaque, that plaque is, it's unstable, it's angry. The risk of a second and potentially much worse stroke is sky high in the hours and days right after. Time is brain, and we have to do something. And that leads us directly to the big dilemma. We know we need to act, but what's the best move? Do we go in for an open surgical cleanout, a carotid endarterectomy, or do we opt for a less invasive stent? And critically, does the answer change if we get in there within a few days versus waiting a week or more? That is the exact question this massive piece of research was designed to answer.
Now, to answer a question like that, you can't just go with your gut feeling. You need to cite the evidence, and we're going to look at the powerful, solid foundation of data that guides what we do today.
The evidence we have isn't from just one single study. It's from a huge pooled analysis. Now, this is a really high-level way of doing things, where researchers took the individual patient data from 4 of the biggest, most important randomized controlled trials in this field and combined it all. Doing it this way gives us incredible statistical power to see patterns that you might miss in the smaller trials.
And these are the heavy hitters of carotid research: EVA3S, SPACE, ICSS, and CREST. All told, we're looking at data from over 4,100 symptomatic patients. Each one was randomly assigned to get one of 2 procedures, giving us this incredibly robust data set to compare the outcomes.
Just so we're all crystal clear on what was being compared, in one corner you have carotid artery stenting, or CAS, the endovascular approach, and in the other corner, the long-standing gold standard, carotid endarterectomy, or CEA, the open surgical approach. The researchers were laser-focused on safety, specifically within that first month after the procedure. The primary endpoint, the big one, was the combined risk of any stroke or death. But they also looked at any stroke on its own and, just as important, the risk of a really bad one, a fatal or disabling stroke.
All right, now for the main event. This is the part of the answer that carries the most weight. These are the numbers you absolutely, positively have to know. So what did this huge analysis actually find?
The analysis really drilled down into that super critical time period. What happens when you treat these patients urgently? Within 1 week of their TIA or stroke.
Okay, for patients who got a carotid stent within those first 7 days, the risk of having a stroke or dying within 30 days was 8.3%. Burn that number into your brain. Now, for the patients who had the open surgery, the carotid endarterectomy, in that same early window, the risk was just 1.3%.
And this just says it all. It is not a subtle finding. When you see those bars side by side, it's not even a close call. The risk with early stenting is more than 6 times higher than the risk of early surgery. It's a massive, clinically significant difference. So you might be wondering, okay, but what if treatment was delayed past a week? Well, stenting was still riskier than surgery, 7.1% versus 3.6%. The gap narrows a bit, for sure, but endarterectomy is still the safer procedure, no matter how you slice it. The data really suggests that an unstable plaque just does not like being manipulated with wires and a stent.
Okay, now for the part that will take your answer from good to great. You have to acknowledge the limitations. No study is perfect, and showing that you understand the nuances demonstrates a real consultant-level critical appraisal. So, the big point to make is that this was a post hoc analysis. What does that mean? It means the original trials didn't randomize patients to the timing of their treatment, only to the type of treatment. We also don't have detailed imaging to know which patients had fresh strokes on their brain scans. And finally, the use of those little embolic protection devices during stenting wasn't consistent across the board, and that could definitely affect the outcomes. These are really important caveats to mention.
But here's the thing. Even with those limitations, the signal from the data was just so strong that it had a huge impact. So what does all this mean for the actual patient sitting in front of you? What's the so what?
Well, the authors of the analysis spelled it out perfectly. Their conclusion is completely unambiguous. For a symptomatic patient, getting an early carotid endarterectomy offers the best shot at preventing a future stroke with the lowest risk from the procedure itself. This evidence is the bedrock of our current clinical guidelines.
Okay, we've walked through all the components. Now, let's assemble them into that concise, polished, confident answer that you're going to deliver in your exam.
Here it is. This is your framework. You start by stating the clinical problem, that high early recurrence risk. Then you name your evidence. The carotid stenosis trial is collaboration pooled analysis of those 4 major trials. Now you deliver the killer statistic. The 30-day stroke or death risk for early intervention is 8.3% for stenting versus a much, much lower 1.3% for surgery. Then state the clear conclusion. Early surgery is safer. And you finish with that sophisticated caveat. Just acknowledge it was a post hoc analysis.
So let's put it all together. If you're asked in the exam, the safe consultant-level answer is this. Early surgical intervention with carotid endarterectomy is the safest, evidence-based approach for symptomatic patients, as it carries a substantially lower peri-procedural risk of stroke or death compared to stenting, especially within the first 7 days after the initial neurologic event. It's clear, it's confident, and it's correct. This whole case is just a powerful reminder that in surgery, when we intervene, can be every bit as critical as how we intervene.